Can you imagine walking a mile just one day after surgery? It's doctor's orders following a surgical technique for a common pain. Our expert shows and tells all coming up now on the Morning Medical Update. And good morning. It is finally Friday. It's August 26th. I'm Jessica Lovell. Welcome into the Morning Medical Update. We are live here inside the Dulcie Simons Jr. Family Broadcast Studio. Just 90 minutes away, you can participate in a health summit tracking common conditions by zip code. Also, COVID cases jumped just a bit recently, but where are we today? And why it's not your grandfather's hernia surgery anymore. Surgeon Dr. Benjamin Stone is here. He is our hernia expert today. You're going to explain why and how you get your patients home and on their way to feeling well after their hernia surgery just in one day, right?
Absolutely.
All right, we're going to hear all about that. And that's kind of a big wow. So we're going to find out how you do it. So send in your questions about hernias and all things COVID or monkeypox. You can use that chat feed or you can email us. The links are right there on your screen. Your zip code could determine your access to health care. So how do we make it equal for everyone? Neurologist Dr. Carol Ulloa from the University of Kansas Health System and Dr. Geraldine McGee, Vice Chancellor for Diversity, Equity, and Inclusion for KU Medical Center. They both join us today to tell us about an event aiming to do just that. Ladies, good morning to both of you.
Good morning.
Good morning. Good to see you both. Dr. McGee, I'm going to start with you. There's an important event happening this morning. Can you share with us exactly what that is?
Absolutely. Good morning, Jess, and good morning, Dr. Stone, and good morning, everyone. Thank you for having me on today. This morning, beginning at 9:30, is our second annual Health Outcomes Assembly. This assembly is a partnership between KU Medical Center and KU Health System, as our missions align with improving the lives of Kansans and beyond. We started this important initiative last year to unpack the healthcare disparities affecting marginalized communities and find tangible ways to mitigate those disparities. This year, we're focusing on health disparities between counties and zip codes.
All right, if you are interested in joining this conversation, we put a QR code on your screen right now so that you can register. If you miss it, but you want more information, you can go to bit.ly/MMU Health Summit. So just want to put that info out there. Dr. Ulloa, on to you next. Can you tell us about the purpose of the event and kind of how this all came about?
Sure. So essentially, as I became more aware of healthcare disparities, and what I mean by that is, you could have two people with the same disease process, baseline characteristics, but different race or different zip code, and essentially they can have very different outcomes. So I wanted to do more with my platform as a physician leader to impart change. And I felt that a conference aimed at this issue involving various disciplines, specialties, community leaders and partners could really help educate and hopefully create some solutions. So initially I took my idea to Dr. McGee, who was very supportive. Then I had further discussions with Dean Ojo, with Tammy Peterman, Dr. Steve Stites. And this is how it became a joint effort between University of Kansas Medical Center and the health system, with the first year being last year and this being our second.
Dr. McGee, so tell us who should attend this event today and what should be the big takeaway for them?
Absolutely. So everyone, all healthcare professionals, clinicians, scientists, organizational leaders, lawmakers, community members, community partners, patients, family members, advocates, everyone is welcome. Kansas, Missouri, everyone in our region, because the information that will be shared today is for all. It's for every one of us, so we welcome all to attend.
So again, we want to remind you there is a QR code on your screen if you want to register. Again, the assembly is today at noon, it's from 9:30 to noon here, just about an hour and a half. So check that out. And ladies, just thank you so much for all the work that you do in this really, really important area of healthcare. We really appreciate you. Thanks for sharing today.
Absolutely.
Well, ask anyone who's had a hernia and they'll tell you it's absolutely no fun. Hernia surgery used to mean days of recovery in the hospital and several weeks of soreness and pain. But that is changing thanks to evolving techniques in the operating room. Bob Hallinan shows us, and he caught up with Gary Witzel just before his procedure.
It's starting to get just a little bit more uncomfortable.
Gary Witzel has not one, but two hernias that need repair.
Well, I've kind of toned down on my heavy-duty work the last couple weeks.
We caught up with him as he was being prepped for surgery with Dr. Benjamin Stone.
I'd like for you to give it 2 days where you're keeping things clean and dry.
Dr. Stone has been repairing hernias for a long time. He does both laparoscopic and robotic procedures, each minimally invasive. He's found a way to dramatically cut down the pain and the recovery time starting in the OR. He uses nerve blocks and specific operating techniques.
Hernias and hernia repairs, even in the short 20 years that I've been in medicine, the management, the repair, the recovery has changed drastically. And it's not your grandfather's or even your father's repair.
And there's one more thing that surprises patients. When they go home, they leave with a prescription from Dr. Stone that they can fill with their own 2 feet.
I also ask him to start walking today as much as he can, and tomorrow morning he'll do a mile, and then the day after that he'll do 2 miles. Usually after that second day of walking, most of my patients will tell me that pain and soreness really aren't a factor in their recovery.
That was music to Gary's ears, who was eager to get started on the 45-minute procedure. Dr. Stone used the robotic method on Gary, which allows him to replicate the kind of motion that we have with our hands, only with more precision.
I can see better robotically than I can with my own eyes.
That's pretty good.
That translates into less post-operative pain and quicker recovery.
Hey.
Are you loopy?
Just a little bit.
After the procedure, Gary was a little groggy, but said he was feeling great, looking forward to going home the same day. Sure enough, Gary was following his doctor's orders the next day. Out walking a mile, heading down the road to recovery.
And Dr. Stone is right here beside me this morning. How are you?
Doing well, Jessica.
All right, so I gotta ask, what is the reaction when you tell your patients, guess what? I'm gonna do this surgery today, and guess what you're gonna be doing tomorrow? Walking a mile.
It's usually a very predictable eyebrow raise, and if they've got anyone with them, that there's usually a laugh, and then the reality sets in that this is something that will help you out. This is something that will help you feel better, do better, and get back to your baseline a little bit more quickly.
Well, and I think that's it. People want to think, well, what can I do? I don't want to just sit around, lay around. People say, go home, put your feet up, stay out, just rest. And no one wants to do that anymore. They want to go, how can I play an active role in getting back to me? So what makes someone a good candidate for this? So like Gary, for like a minimally invasive surgery versus maybe what we think of as a traditional hernia surgery.
Sure. So just to compare and contrast, we used to tell people, even when I finished my training 14, 15 years ago, we used to tell people, we want you to take it easy, we want you to relax, not do a lot of lifting. For a good 6 weeks, don't lift anything heavier than a milk jug. And now, as you can see, what I had Gary do was get out of bed, or not even get in the bed. And what we found is that if we never lose that physiologic conditioning, and that exercise stamina, that people do better. And that's not just with this type of case. That's true in the literature. If you look through the neurosurgical literature, the orthopedic literature, the cardiothoracic literature, that there are benefits from keeping people active and keeping people moving. And so, go ahead.
No, I love seeing him up here walking. He looks like he's doing quite well. So I think Gary, in this case, didn't know that he had a hernia. So if you've never had one before, how would you even know you have one? What type of signs or symptoms might I look for?
Sure. Well, different hernias will show up differently for different people. But for most people, in particular, about 75% of all hernias are groin hernias. And men will have about 90% of those hernias. And so it will usually show up as a bulge in the groin. Sometimes, and for different people, you have varying amounts of discomfort. For some people, they notice that, every time that I'm up and at the end of the day, I've got some soreness after a full day's work.
Okay.
For some people, they will say, it's gone from letting me know that it's there to it affects what I do, and I can't do certain things. I can't, if I cough, or if I'm sitting in my car for a long time, or if I'm trying to pull weeds, it aggravates me.
So might I feel it, or feel it physically with the pain, or feel it like with my hand more? What would you see it or feel it first?
You can do both.
Okay.
A lot of people will say, you know what, I was getting dressed and I looked down and I saw a bulge that hadn't been there before, and that's their first clue. For some people, it's a discomfort when I do X, Y, or Z that usually involves something where you're straining even minimally.
So, okay, I want to put some information up. We have a bit.ly link on your screen for more information about hernias, the causes, the signs, the symptoms. For those joining us on podcast, that is bit.ly/MMU hernia. What might cause it?
So, good question. So, I'll say there are three categories of things that can cause a hernia. Genetics plays a role. Some anatomy and physiology. There are some differences between male and female that are the reasons that men tend to get these hernias more frequently. And then there are those modifiable risk factors. But starting with genetics, there have been some good epidemiological studies that have looked at the types of collagen that are in our body, and there are a number of different types. The collagen that we think of as the structural collagen, so like in our bones and our ligaments and our abdominal wall, it's a very strong collagen. It's very well cross-linked, and it helps hold us together. And that's type 1 collagen. Type 3, people with a predominance of type 3 collagen, they tend to have hernias at a higher rate. And so we see that show up in families with a history of hernias. You're about 8 times more likely to have a hernia. And a lot of that probably has to do with the types of collagen that are present and the ratios of collagen that are present in your body.
I'm glad you asked that, because that's a question we get a lot from our audience. Is this hereditary? You know, am I more prone to it than someone else? But interesting about the men over the women. I think that's I think that's what we maybe think of or associate first, that men get them more.
Yes, about 1 in 3 men will develop a groin hernia over their lifetime, whereas only about 3% of women will develop the same, and that has to do with the anatomic situations that are going on when we're still in development in our mother's wombs.
Interesting. Okay. I want to talk about new advancements in hernia care that we had talked about. There's new advancements with abdominal reconstruction. Tell us a little bit about that and who might need that type of reconstruction.
Certainly. So usually first-time repairs of hernias, whether they're in the groin or whether they're in the abdominal wall in the front, usually we can just put those back together, and those are simple repairs. After an initial hernia repair, we move into the more complex hernia repairs for people that have had 2 or 3 or 4 hernias that need reconstructed, where the abdominal wall is no longer together. And people are starting to lose the ability to bring things back together. There have been a lot of advancements with the better understanding of the anatomy, the physiology, and then marrying that with the advancements in technology. So you'd asked initially about who's a good candidate for laparoscopic surgery. And what laparoscopic and robotic surgery have offered are a better and deeper understanding of how to put things back together, and how to do it in a way that patients have less pain, fewer problems with wound infections, and a quicker recovery.
Do you still use the scalpel method? And why would you use that over laparoscopic or robotic?
Certainly. So a lot of times the health problems that people come with at the time with their hernia, so people with heart problems, people with lung issues like COPD or chronic obstructive pulmonary disease, or if the heart isn't pumping strongly enough, there are some factors during surgery that make them less ideal for things like robotic surgery or laparoscopic surgery. I have to put some carbon dioxide in the belly, and that carbon dioxide presses on things, including the heart and the lungs. And so people who are already on the fence as far as how well their heart's working, how well their lungs are working, that requires some judgment and to determine who's a good candidate for robotic surgery and who is not. That said, for people who don't have those comorbid conditions, everyone's a fantastic candidate for either a laparoscopic or robotic approach.
Okay, now I always thought those two were kind of one and the same. So what is the difference between the robotic and the laparoscopic?
So I'll say in the mid-1990s, laparoscopy really started catching on. And instead of making a big incision to put my hands in there to operate, we can do the same procedures through 5 and 8 millimeter incisions. And I can put tools in instead of my hands that replicate some of the motions that I can do, moving up, down, left, right, in and out, and even some twirling motion. And that allowed us to do things like take gallbladders out, changing it from a 3-day hospital procedure to an outpatient procedure, or take an appendix out with an overnight stay instead of 3 or 4 days.
Simply less invasive.
Less invasive. Better outcomes.
Better outcomes.
Now, robotic surgery, and you'll see on the screen there, I'm able to perform a lot more complex motions that more closely replicate and resemble what I can do with my hands as far as the articulation goes. I've got 7 degrees of freedom, or 7 degrees of motion rotation that I can go through on the robotic platform, as opposed to about 4 with the laparoscopic.
That's what I was going to say. You're not getting in there in the same way as you are that we're seeing here on the screen. All right, we've got some questions coming in for you, but I want to get to Dr. Dana Hawkinson,
Sure.
Medical Director of Infection Prevention and Control. He's got our COVID and our monkeypox count for this morning. Happy Friday to you. How are the numbers looking?
You know, COVID count's really pretty good. The active infections have gone down under 20. We're certainly happy about that. 17 active infections, 1 in the ICU, none on the ventilator. Still 17 in that recovery period. And we do know about monkeypox. Monkeypox cases are still increasing, but not as much. And so I think that is overall going well. Again, I think the messaging is getting out to the right populations. In addition, we now have preventive methods as we are giving more and more of the Jynneos around the nation. Here at the health system, we have given just under 100 doses of that smallpox vaccine Jynneos. So it's going well. We would certainly like to get as many people vaccinated as possible. And you can see the numbers right there. The epidemiologic curve, the number of cases, like I said, has slowed down. We were increasing quite a bit. Right now we have 16,000 cases in the United States. Still more being detected, and I think we will see more, but hopefully the overall number and speed of rise of that case curve will continue to decrease.
So on what you just mentioned,
Yeah.
overall,
Yeah.
the World Health Organization
Yeah.
saying monkeypox cases are down by 21%. That sounds great, but what do we think this will mean for the long term or even the short term?
You know, I think for the next 2 to 4 weeks, I think we still want to see what that curve is going to be like, the number of cases. But also, we know that messaging has been very good, and we know those highest at-risk populations are trying to do the right things, the non-pharmaceutical interventions, which basically is distance at this point and not engaging in those intimate contacts right now. But then also we have those pharmaceutical interventions, especially here in the United States as compared to some other countries, and that is the ability to give that vaccine. Hopefully that will continue, and we will build up immunity and see lower and lower case rates in our specific communities, but in the nation as a whole as well.
So a new study out of Jerusalem finds that Paxlovid reduces the risk of
Yeah.
COVID-19 deaths by 81%. That's COVID-19 deaths. Yeah, we hear a lot of people getting rebound cases after they take it. So can you kind of explain what that means or why that's happening?
Yeah, I think these are really 2 separate issues. So there was a study out of New England Journal of Medicine out of Israel this week, and it did show exactly what we believed. And Paxlovid reduced those risks by 80%, but it was specifically for those age groups that were 65 and above. We know that had the largest impact. If you were in that 40 to 65 or 64 age group, it didn't seem to have the same benefit as it did for those older groups. But I think that is important to understand that, and we continue to hit home, especially if you were high risk, i.e. Over a certain age, 60 or 65. If you have symptoms, get tested early, get on Paxlovid. The other thing, again, for those rebound cases, we are still monitoring those. There's really been nothing to suggest that you do worse with rebound cases. Still no deaths that I'm aware of. So those things will continue to happen, but really nothing specific, nothing more severe if you do have a rebound case after taking Paxlovid.
So a new report finding that COVID incubation time gets shorter with each new variant. So what does that tell us about how to protect ourselves and certainly other people around us?
Yeah, I think this is more of just, there's a lot of caveats to this study. First of all, it was a meta-analysis, so it was looking at a large number of different studies. Also, those studies were all retrospective, so that meaning they have to go back and look at charts or ask patients going backward in time to look at when their first symptoms. I don't think this holds much weight as far as the knowledge about SARS-CoV-2 overall. We know that some of the effect of immunity, so again, most safest through vaccination, but also previous infection, is going to allow your body to develop symptoms earlier because that is your immune system kicking into gear to protect you from the acute infection. So I don't hold a lot of weight in this. I think what we really need to look at are the severity indexes, severity scores, deaths, and we really know that all of the variants have been the same throughout, except for maybe Delta, where you maybe had a higher risk of severe disease, but really all the other variants have been the same. And again, the thing that is going to reduce your risk of death and severe disease is going to be up to date with vaccination as well.
I have some viewer questions, and Dr. Hawkinson, I'm going to just stick with you. Jenna asks, why is the pediatric COVID vaccine 3 shots instead of 2 to be considered fully vaccinated?
Mm-hmm. Yeah, that's just what they found in the studies. They found that it was better to give that 3rd dose. And again, 3 doses is nothing unusual. We have 3-dose vaccines for a number of different things. I believe polio is at least 3. We know hepatitis B is. That is just what they found in the clinical trials that they were doing. Again, practicing evidence-based medicine, we are looking at those data. We are analyzing those data and making our conclusions based off of that.
Karen is asking, if I still need that second booster, should I get the current booster or wait for the new one? We get that question a lot, so let's answer it.
We do, and I think, again, it comes down to individual risk. If you were 50 and above, and especially if you had other comorbid conditions, you should have had that second booster already. At this point in time, I think most people, if you're not highest risk, are really going to recommend that you wait until, I think another week or 14 days. And by that time, there will be that new booster rolling out. There will also be final new recommendations, we believe, especially coming out in that first week of September, so not too long now.
And how long after COVID infection do we get a flu shot? That's a good question. We're getting into flu season.
Yeah, I mean, you can get any vaccine after COVID infection when you are able to go back out into society. So when you are done isolating, you are able to really get any vaccine.
All right, I have a question for Dr. Stone. Linda wants to know, what's the chance of a hernia coming back? If I get one, am I likely to get another? Or the same one coming back? Or
So regardless of the type of repair you have, whether it's open, whether it's laparoscopic or robotic, the risk of your hernia reoccurring depends on the risk factors that you bring. At best, about 1%. So I expect 99% of people who have a hernia repaired that don't have a lot of extra risk factors, diabetes, smoking, obesity, I expect 99% of them to stay repaired forever and about 1% to recur.
Linda wants to know Victoria wants to know, what's a hernia mesh?
So that's a great question, and there are lots of different kinds of meshes. The way that things have evolved are that we try to use a mesh that's inert as far as its interaction with the body. The mesh is not interacting with the body, but the body's allowed to interact with it. So, for instance, 20 years ago, we used to use a lot heavier weight meshes that were more seen as a barrier to prevent things from moving outside of a hole. That's all a hernia is a hole. And so you'd put a large barrier so that things couldn't move through that hole. We've had a paradigm shift on how we understand the physiology of a hernia. And now we put a mesh that allows the body to weave in and out of the interstices of that mesh to incorporate that mesh into the body wall. And we found that that's a much better way of repairing the hernia so that it stays repaired. It also cuts down on the risk for infection with mesh. And we've moved from having very heavy barriers to having what we call now medium weight meshes. They're more comfortable for people. The body's able to clear infection better from them. And overall, as we've moved forward with our understanding and our knowledge, the technology has allowed people like Gary to realize the benefits of those improvements.
Good morning, Georgianne. You mentioned a little bit of this, Dr. Stone, earlier about how and what causes a hernia, but she's saying she's been hearing this for years, that it's, how do you get that strain? Is it shoveling snow, lifting something heavy? Are all those things still true when it comes to how you get them?
Certainly. You can think of a hernia as a whole, and just like clothing or tires, the more use that you get out of them, the more wear and tear you put on them. Often it's not one event that causes a hernia, but it's an accumulation of wear and tear over a lifetime that can cause a hernia. Certainly lifting heavy objects or straining exposes people to an immediate risk for hernias. But it's multifactorial. We've talked about a little bit about the genetics, some of the anatomic differences between men and women, some of the risk factors such as smoking, obesity, diabetes. all of those factors can contribute to a hernia.
So kind of the perfect storm happens.
Correct.
Here comes the hernia. I knew this question was going to come, and Isaac is asking it. He's seen the infomercials about the class action lawsuits regarding hernia mesh surgery. Do you know anything about that? We talked about meshes getting better, safer, healthier, more comfortable. Just help us understand what those are about.
Sure. Well, like any manufactured item, a refrigerator, a car, there can be issues that come up. We don't stop driving cars because there's a recall on a specific component. Not all meshes have problems, but there are risks with putting a mesh in people, and you can usually modify those risks by addressing the same smoking, diabetes, obesity, risk factors that are pertinent for hernia repair itself. That said, yes, over time the meshes have gotten a lot better. We understand that if you put them in high-risk people, high-risk patients, that it's higher risk for complications and problems. Also, the site that you put a mesh plays a big role in what those risks are. If you have a lot of movement past that mesh, like for instance at the diaphragm, where every breath that we take, our stomach and esophagus slide past a mesh, that's a higher risk area to have a mesh as opposed to the abdominal wall, where we don't have things traversing the path that our mesh is crossing. And so for the groin, you should consider mesh repair actually to be kind of the gold standard of how hernias are repaired. It's extremely low risk at that site and with the current technology that we have in place for mesh.
So my question for you is, what questions, I mean, you're so spot on and you know so much about this, you're so specialized, but if I'm coming to you, I've never had a hernia before, I don't know much about it, what questions as a patient should I be asking my physician about my possible treatment or care?
Sure. So most people, you don't need to have a medical education to understand pain and discomfort and how that might interact with your ability to enjoy time with your family, your friends, to do your job and do your work. And so my goal as someone who specializes in hernia care is to alleviate pain and suffering from hernias and get people back to the things they want to be doing. I think some of the technical aspects of a hernia repair that are good questions to go in so that you're going in with your eyes open are: what are the risks? What are the benefits of having this hernia repair? And what are my options? The benefits, as I see it, for laparoscopic and robotic hernia repairs, we tend to have a little bit fewer complications with chronic nerve pain in that we're often not anchoring this mesh to the body wall the same way that we would do with a traditional open repair. And about 1% to 2% of people can have some chronic nerve pain, and we can reduce that by using one of these minimally invasive techniques. You should want to know what are my specific risks for recurrence of this hernia, and what can I do to minimize those risks. Often that involves getting a body mass index to a healthy rate or a healthy level. Optimally between 22 and 25 is where I'd like to see most BMIs to help reduce the risk of hernia recurrence. But for every point that you drop, you benefit yourself for perioperative risks, infections, pneumonias, as well as hernia recurrence risks.
A couple more questions. Emily wants to know, can hernia repair be done in combo with other surgeries? Sure.
Good question. And I often end up doing a lot of cases with my obstetrics and gynecology colleagues, with the urologists. And so yes, there are certain cases where it would be advisable to combine a case and minimize how much surgery or how many times someone's going to sleep for a surgery. There are certain other cases that, for instance, if we're traversing the intestines or doing something that has a large load of bacteria, where it would not be a good idea to combine hernia cases. And so that's usually a conversation between the surgeons that would be coordinating those cases. But
Catherine wants to know, can a hernia heal on its own?
So, interesting question, Catherine, that up to about age 5, some hernias will heal on their own. Once we hit about age 5, a lot of those cells in our bodies that can find a problem and fix it, the ratio of those cells goes down. And so after about age 5, we don't see hernias spontaneously healing. And so for a mechanical defect, it usually requires a mechanical solution in the form of some type of operative repair.
So that leads to my question, how young have you seen hernias? Like, can children get them? Are they rare? Tell us about that.
Certainly. So the process of, and this goes back to some of the anatomic considerations. So for men, our testicles start inside of our abdomen, and then as we grow inside of our mother's womb, they descend through the abdominal wall to rest in the scrotum. And so they create a hole in the abdominal wall, and normally that hole is only big enough for the artery and vein to fit through. But sometimes that process doesn't complete, and things don't close down, and so people will be born with a hernia. The reason that men get hernias more frequently is that as we go through life and just have wear and tear, that hole that's created for the blood vessels to pass down to the testicles, sometimes it gets stretched out. And so instead of being nice and tight right around those cord structures, it gets stretched out and things can slide down where they're not supposed to. And that's all a hernia is, just a hole.
All I've known about hernias my whole life is that I've never had one. So you are giving me so much information. I'm loving this. Okay, so question from Yen Liang. And this is tough because you want people to stay active, but he wants to know, would mountain climbing and weightlifting lead to hernias? I guess if you do them right or wrong, does it matter? You could still get them no matter even if you're lifting weights right and correctly. You're just either going to get it or you're not.
Well, so my lifting coach, I had a lifting coach in college, and he would always, you got to breathe as you're lifting.
Okay.
And so what we find is that anything that what we call a Valsalva maneuver, where you increase your intra-abdominal pressure, that puts strain on the intra-abdominal compartment, and it tends to push things outward.
Yeah.
And so if you're doing things that do cause you to strain frequently, yes, that's a risk factor. It doesn't necessarily mean that all lifting will result in a hernia, or mountain climbing will result in a hernia. I usually encourage my patients, even those with hernias, if you're not having pain, you can continue to do the things that you enjoy.
And how should someone choose their surgeon for their hernia repair? Again, it kind of goes back to what questions to ask, but how do you know you're in the right spot? Especially, again, you've never had one before, so here you are.
Sure, and that's a tough place, I imagine, as a patient to be, not knowing what's on the other side of the curtain while you're asleep. I think finding a surgeon who's part of the American College of Surgeons is a good start. What that means is that as a member of the American College of Surgeons, I've dedicated myself to maintaining a high level of knowledge, of expertise when it comes to the care of surgical patients. And you can find that information on the American College of Surgeons website. You can look for someone who has an interest and a specialty in hernia repair. For most people trained in the United States with a general surgery training, that is kind of the bread and butter of what we do. For some of the more complex things, you'll probably be looking at a tertiary referral care center like KU to find people with extra specialized knowledge in abdominal wall reconstruction and some of the more complex techniques.
Like you.
Sure.
I said, I'm coming your way if I ever get one. I don't want one, but I'm going to hunt you down if I do. Okay, Kathy, I think this is going to be our last question. Kathy wants to know, if you had a groin hernia on one side, is the other side automatically at risk?
Not necessarily so. Okay. And again, a lot of things will go back to some of those risk factors that we determined earlier. If you have less type 1 collagen to start with, then yes, you have less type 1 collagen on the other side as well. If you're a smoker, that exposes you to risk because of its interaction with the types of collagen in our body. There's something called the metallomatrix proteinase system that keeps in balance building up proteins and tearing down proteins. And that's how smoking interacts with things. It changes that balance so that there's more tear down of structural proteins than build up. And so I'll say that's a tough question to answer because it depends on a lot of things.
Goes back to those factors that
Yes.
you said. Everything comes into play all at once. Such a great questions today, everyone, and just such a great topic. And I learned a lot. So thank you for being here with me today. I want to get to our final thoughts, and I'm just going to let you get us started on is there anything I didn't ask you? Is there anything you want folks to know?
So I think it's a fantastic time to be involved and to see some of the paradigm shifts that are happening with our understanding of the basic sciences. As I talk about the collagen, one thing I didn't get to mention was our understanding of the inflammatory cycle. And what we saw in Gary's photo and videos was that we were able to get him back on his feet so that he really essentially had no downtime, had minimal to no pain during his recovery for a bilateral hernia repair. And our understanding of the inflammatory cycle, how does the body respond to injury, how does the body heal, have led to improvements in patient care. In that we understand that all of the pain, swelling, discomfort associated with having a surgery is related to the inflammatory cycle. And if we can minimize how much of the inflammatory cycle we're stirring up by doing minimally invasive procedures, if we can mitigate some of that inflammatory response with anti-inflammatory medications, and if we can keep people on their feet so that those inflammatory mediators don't have time to build up in that location that we've done surgery, what you've seen with Gary is exactly what we should expect, that we can do complex surgeries, we can have essentially very minimal recovery time, and patients can have things that used to cause a lot of pain. And I think Gary told me right after surgery, I rate my pain 0 out of 10, which is fantastic.
As a doctor, that's all you want to hear.
Absolutely.
Is it fair to say you don't want to ever let this go too long, though? I mean, is this something you have to get taken care of?
A good question, and there's been a lot of study on that. We used to tell people, everyone that had a hernia, you need to have it fixed. Sometimes we'll do watchful waiting for people who don't have a lot of risk factors for their hernia becoming incarcerated, meaning it's stuck there, or strangulated, meaning that the blood vessels are squeezed off. And that's usually case by case, looking at what the risk factors are, looking at what the hernia is, how it's behaving.
Right. And what you shared today is telling people it's okay to come in and get it. It's minimally invasive, and we're going to get you back from a 10 to a 0, right?
That's always the goal.
I love it.
But I think it's always a good idea to start with your primary care doctor, ask them about a hernia if you think you have one, and if you need to come see someone that specializes in that, usually we can find a tailored solution specific to your hernia, your risk factors as well.
A lot of great questions today, so you'll have to come back, okay? Promise?
Thank you.
All right, sounds good. Dr. Hawkinson, final thoughts on this Friday?
Just thanks to our guests, just great surgical subspecialties here, a lot of training, and obviously very knowledgeable. So yeah, please get that done. I think that goes back to what we were talking about, prevention. Make sure you're up to date with all of your preventive needs, your screenings, things of that nature, obviously vaccinations. We are looking for new recommendations for the fall to come out fairly soon here within the next week to 10 days. I believe the committee is meeting on September 1st or 2nd, so we'll have more information after that, and everybody have a good weekend.
All right, Dr. Hawkinson, thanks so much. Preseason game of the year last night, but took a loss with their #1 draft pick. Cornerback Trent McDuffie, he was removed during the first quarter of the game for a possible concussion. So how are concussions treated? We spoke to the team here at the health system responsible for the players' care.
People are very aware of concussion symptoms, and the biggest thing, especially early on for the youth kids and the high schools, when in doubt, sit them out. You don't want to take any chances with that. And another thing is how you play the game, how you're taught to tackle. And you see with the NFL, they've made some changes to their rules where it's a less violent game, less chance of having head injuries. And there's been a lot of improvements in the helmet technologies.
Yeah, the injuries on these fields probably happen at a higher velocity. I mean, you've seen an NFL hit. It's really unprecedented amongst other sports, but a lot of the injuries actually are at the same at many levels. And so I think being able to care for these guys at this level really helps us take care of those sprains and strains, but also the more severe ligamentous injuries, things like ACL injuries, shoulder instability, MCL sprains, meniscal tears. So those would all be common ones that we take care of.
We have the weekend warriors and the people that maybe haven't been as active as they want, and the weather's good now. They start playing these recreational sports, and they have multiple injuries, same kind of injuries that we would see on Chiefs players or high-level athletes, and we're there for them too.
And the Chiefs begin their regular season September 11th in Phoenix. Thank you so much for being here with us this morning and sending in all your great questions. Don't forget you can catch our updates anytime by logging onto Facebook, YouTube, and Twitter. Go out, make it a great weekend, and we'll see you back here Monday at 8 a.m. More than 40 million adults experience an anxiety disorder each year, and one man claims your anxiety could be lying to you. I'm Jessica Lovell. How to recognize anxiety in both adults and children. What you need to know and why. Monday at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.